Hi. So this is the part 2 of cardiology revision. Part 1 had like 4 subparts, but I think the part 2 is gonna be shorter because there were a lot of overlaps between the topics. So that is that, and also overlap is the word I have been searching for in the past videos when I wanted to connect two topics. Before we go into the revision, I just wanted to tell hi to Abdullah Ashraf. Thank you for the thumbs up. It did make me happy and motivated me. And also I saw new 6 subscribers that made me self-conscious, and I'll try to keep the videos with as little mistakes as possible. So in this part 2 we are gonna begin with the topic assessing the risk of thromboembolic events with intracranial hemorrhage. Assessing the risk of thromboembolic events with intracranial hemorrhage. However, there are a few other topics in this part which are also going to be criteria based, so I'll do them all together, then I'll go to the other parts, although I have written them in separate topic between topics. So the first one is assessing thromboembolic risk. Second is infective endocarditis, and also surgical indications for infective endocarditis, that is also criteria based. And valve replacement in aortic stenosis, when the patient needs aortic stenosis. Pre-test probability of CAD, so when we need to do further testings for people who are probably gonna get coronary artery disease. And also the wide complex QT. What do we do when we see a wide complex QT? So how to assess the risk of thromboembolic events with intracranial hemorrhage is that CHA2 DS2 VASE score. I'm gonna remember this as CHA2 DIS2 VASI2, CHA2 DIS2 VASI2. So C is for congestive heart failure, H is for hypertension, A is for age, D is for DM, diabetes mellitus, S is CHA2 DIS2, S is for stroke, transient ischemic attack, thromboembolism, and V is for vascular disease like previous MI, peripheral arterial disease, or aortic plaque. And then A is age again. The first A2 age was greater than or equal to 75. This age is 65 to 74. Patient is assigned between one of these categories. And SC is 6th category, that is female, if the patient is female. So all of these things have a score of 1 except for age and stroke, transient ischemic attack, or thromboembolism. Only these two have the score of 2. Everything else has a score of 1. So congestive heart failure is a score of 1. Hypertension gets score 1. And CHA2 age greater than 75 gets a score of 2. And this D, diabetes mellitus, gets a score of 1. S, stroke, transient ischemic attack, thromboembolic events get a score of 2. And then CHA-DIS2, vascular disease like peripheral artery disease, previous MI, aortic plaque, vascular disease gets a score of 1. CHA2, DISC2, DISC2, VASI2. P is taken care of, and age 65 to 70, especially if it's a female. They get a score of 1, and CHA2, DISC2, and sex. No, this A had no sexual, A does not differentiate between sex, but S2. Sex has a, female sex has a score of 1. And if the score is about 2 or equal to 2, then there is a high risk, and we need to manage with the anticoagulation therapy. So what is the best anticoagulation therapy? Is that apixaban. Apixaban is a non-vitamin K antagonist, oral anticoagulant. I'm sorry, NOAC. Like apixaban is a non-vitamin K antagonist, oral anticoagulant. What are the some of the other anticoagulants? Are dabigatran, rivaroxaban, edoxaban. Dabigatran, rivaroxaban, and edoxaban. So what does this apixaban do? Is it inhibits factor SXA and preventing the cleaving of prothrombin to thrombin. This factor SA facilitates cleaving of prothrombin to thrombin, and this NOAC, non-vitamin K antagonist, oral anticoagulant, prevents this cleaving of prothrombin to thrombin by inhibiting factor XA. So patient on NOACs generally don't need routine INR testing, and thromboembolic risk is high with treatment of clopidogrel and aspirin than with NOACs. And also I just have what happens if the score is below 2. If the score is 0, we do not initiate any antithrombic therapy. If the score is 1, maybe the risk is intermediate, so we don't do nothing, or we start them on aspirin or oral anticoagulants. And if the score is greater than 2 or equal to 2, then they are managed with oral anticoagulants. So the next one, as I said, would be infective endocarditis. This is called modified Duke criteria, and the diagnostic criteria for infective endocarditis is there are 2 major criteria and minor criteria. So definite infective endocarditis is 2 major or 1 major plus 3 minor. 2 major criteria plus 1 major plus 3 minor criteria, and possible II could be 1 major plus 1 minor or 3 minor criteria. 1 major plus 3 minor criteria is definitive IE, and possible IE is 1 major plus 1 minor, or 1 major plus 1 minor, or just 3 minor criteria. So what are this major criteria? Is blood culture positive for typical organisms. What are those typical microorganisms? Staphylococcus aureus, Enterococcus, viridans, streptococci. Staphylococcus aureus, Enterococcus viridans, streptococci. And the echocardiogram showing valvular vegetation. Of course, if the echocardio shows the valvular vegetation, infective endocarditis is the major possibility. And what are the minor criteria? Predisposing cardiac lesion, intravenous drug use, and temperature more than 38 degrees Celsius, which is 100.4 Fahrenheit. Embolic phenomena, immunologic phenomena, example glomerulonephritis, positive blood culture not meeting above criteria. Positive blood culture not meeting above criteria. So what are the minor criteria? Predisposing cardiac lesion, intravenous drug use, temperature more than 100 Fahrenheit, 100.4 Fahrenheit, that is 38 degrees Celsius, embolic phenomena, immunologic phenomena like glomerulonephritis, positive blood culture not meeting the above criteria, and the definitive I is 2 major or 1 major plus 3 minor, and possible infective positive infective endocarditis is 1 major plus 3 minor, or 1 major plus 1 minor, or just 3 minor. And what are the clinical findings in infective endocarditis? Fever, heart murmur. 85% of the people have heart murmur. More than 90% of the people have fever. Potassium, that people less than or equal to 15% people have potassium. And subungual splinter hemorrhage, which is like you see the straight lines in the toenails. Subungual splinter hemorrhage. Osler nodes, Janeway lesions. Osler nodes and Janeway lesions. What is a Osler nodes and Janeway lesion? Is Osler node is this, in this fingers you find a spot, and Janeway lesion is that in your palm, like if you press your palm for a long time, how you see a red colored thing, that is the Janeway lesion. Neurologic phenomena, that is embolic, less than 40%. Neurologic phenomena due to embolus, less than 40% people have that. And splenomegaly, which is less than 30% of people. And rod spots, retinal hemorrhage, in less than 5% of people. So I'll go over the clinical findings once more and the frequency. So the people, more than 90% of the times they have fever, more than 85 times of the time they have heart murmur, more than or less than or equal to 15% people have potassium. And then subungual spider hemorrhages in less than 50% of the people. Osler nodes and Janeway lesions, less than 50% of the people. Neurologic phenomena, embolic, that is in less than or equal to 40% people. Splenomegaly, less than or equal to 30% people. And what is the last one? Let me see if I can recollect it from my brain. Splenomegaly. Oh, that's what I said, sorry. Road spots, hemorrhage, retinal hemorrhage in less than 5% of the people. And the third topic which has the criteria is valve replacement in aortic stenosis. So the severe aortic stenosis criteria are aortic jet velocity more than or equal to 4.0 millisecond, or just this aortic jet velocity of 4.0 just this aortic jet velocity of 4.0 milliseconds is okay to say severe aortic stenosis. Are these two. Mean transvalvular pressure gradient is more than or equal to 40 mmHg. Mean transvalvular pressure is more than 40 mmHg. Both of them have 4, so it should be easy to remember. And valve area is usually less than or equal to 1.0 centimeter 2, but not required. Valve area is usually less than 1.0 centimeter square, but usually it's not required. And the indications for valve replacement: severe AS, so if they have severe AS, what we just read about, or greater than one of the following. Onset of symptoms, example angina, syncope, then they need a valve replacement. Left ventricular ejection fraction is less than 50%, and undergoing other cardiac surgery like CABG. So who needs valvular replacement? People who have met the severe criteria, and people undergoing cardiac surgery. And what was the second one? Left ventricular ejection fraction is less than 50%. Left ventricular ejection fraction is less than 50%. Okay, this is done. And the next one is surgical indications for infective endocarditis. I should have studied that with the infective endocarditis, but anyway, the surgical indications for infective endocarditis is, why are we gonna do surgical indication surgery in an infective endocarditis patient is acute heart failure. Example, aortic mitral valve regurgitation. If the infective endocarditis has led to aortic or mitral regurgitation, it causes acute heart failure, then we are gonna valve replacement or anything to do with the valves that causes acute HF. And extension of infection. Example, abscess, fistula, heart block. If the infective endocarditis has obsession, fistula, heart block, which is the extension of infection, so they need surgery. And difficult to eradicate organisms like fungus, multiple drug resistant pathogens, difficult to treat organisms like fungus and multiple drug resistant pathogens, persistent bacteremia on antibiotics, which is like multiple drug resistant, more or less equal to, and large vegetation, persistent septic emboli. Large vegetation, persistent septic emboli, that is greater than 1 centimeter. If the vegetation is more than 1 centimeter, then we are surely gonna do surgery for the infective endocarditis. And right-sided endocarditis is common in IV drug use. Right-sided endocarditis is more common in IV drug use. They are left hand, right-sided heart failure. Sorry, right-sided infective endocarditis. But sometimes left side is affected too. So this topic is done. And then the pre-test probability of coronary artery disease. The pre-test probability of coronary artery disease, which is topic 29 in my notes. Yeah. So there are 3 categories: low, intermediate, high. If the patient is asymptomatic, people of all ages, there is no probability of coronary artery disease. Atypical chest pain, especially in women, less than 50%. Atypical chest pain, which is in women who are aged less than 50. The intermediate category, the low is less than 10%, and the intermediate low is less than 10% of probability of coronary artery disease. So if you're gonna do the testing or not do the testing, intermediate is 20 to 80%. We need to test the patient. So atypical angina in men of all ages, of course, angina will be going to coronary artery disease. Atypical angina in women greater than or equal to 50 years old, and typical angina in women who's 30 years to 50 years old. Atypical angina in women who are aged more than or equal to 50, and typical angina in women or aged 30 to 50. And the first point was atypical angina in men of all ages. Only the women get the age criteria in the pretest probability of coronary artery disease. And high risk, we are gonna do the testing, is typical angina in men more than 40, typical angina in women more than 60, typical angina in men age more than 40, and typical angina in women more than or equal to 20. So if the risk is low, there is no additional diagnostic testing is needed, because if there is a low risk and we do the testing, we end up doing a lot of procedures which are not needed. And intermediate, if the patient is in the category of intermediate risk, then, and if they are able to exercise, we are going to do the ECG. ECG, if the ECG is, and I don't know how to put it. So if the patient is able to exercise, we are gonna do normal ECG. If the ECG is normal, then exercise ECG test. If the ECG is not normal, then exercise imaging test. And if either the excessive stress test or the exercise imaging test comes positive, we do coronary angiography. And if the patient is not able to exercise, then we are not gonna do the exercise study or exercise imaging test. We are gonna do pharmacologic stress test, which I'll come to it later, what pharmacologic test and how we do it, which is in this part 2 as well. And if that is positive, then coronary angiography is needed. And the high risk, start pharmacological therapy for CAD. Even in part 1, we studied a lot about the CAD drugs, and a few of it is here and there in this part 2 as well. And we need expert evaluation. Start pharmacology therapy and we get expert evaluation. And wide complex QT. This wide complex QT is not a criteria per se, but just like how we approach CAD, this is like how to approach wide complex tachycardia. I said wide complex QT, but no, it is wide complex tachycardia, and the whole QRS wave is wide. I'm so sorry, I mentioned it as QT. The whole QRS waves are wide. QRS is wide. So if see a tachycardia, and if we signs for AV dissociation, the T waves and the P waves are mingled. And also there are fusion capture beats, like fusion capture beats, or where the P waves and T waves are mingled. And we could also see AV dissociation. AV is functioning separately, ventricle is functioning separately, and we find that in ECG. Yeah, so if there is AV dissociation and fusion beats in fusion capture beats in wide complex tachycardia, then we are gonna how are we gonna diagnose the patient with ventricular if there is AV dissociation and fusion capture beats, then we make a diagnosis of ventricular tachycardia. If the patient is stable, then we give them IV amiodarone. If the patient is unstable, then the criteria for patients who are unstable is hypotension, altered mental state, respiratory distress. Then we do synchronized cardioversion. If the patient is unstable, hypotension, respiratory distress, altered mental state, then we do synchronized cardioversion. If there are no AV dissociation and fusion capture beats, but just the QRS complex is wide, then we consider supraventricular tachycardia with aberrancy. Then if the patient is stable, we look for maneuvers to determine maneuvers to determine and regulate the rhythm, like carotid massage in PSVT, paroxysmal ventricular tachycardia, rate control and treat the patient. We control the rate and treat the patient. If the patient does not have AV dissociation and fusion capture beats, but are unstable, hypotension, altered mental state and respiratory distress, then we are gonna do synchronized cardioversion. And also another thing which I missed is the indications for statin therapy, which is also going to be based on a few criteria. So the indications for statin therapy in prevention of atherosclerotic disease, secondary prevention, primary prevention. The primary prevention is the load LDL is more than or equal to 190, age more than 40 with diabetes mellitus. Estimated 10-year risk of ASCVD is more than 7.2 to 10%. But I did not check what are this 10-year risk of atherosclerotic cardiovascular disease. I need to go check it back. Maybe I'll add it in the next part. But if the LDL is more than 190 mg per LDL is more than 190 mg per deciliter, age is greater than 40 or 40 with diabetes mellitus, and the risk 10-year risk of atherosclerotic cardiovascular disease is 7.5% to 10%. Then we initiate statin therapy. And secondary prevention is the patient has established atherosclerotic cardiovascular disease like acute coronary syndrome, stable angina, arterial revascularization, example CABG, and stroke, transient ischemic attack, peripheral artery disease. These are all these people require they already have kind of atherosclerosis, so we are going to start the statins for as a secondary prevention, and this is done too. And let's go back. And so the next one we are gonna study is management of ST elevation in patients with management of ST elevation MI. So the drugs we are gonna use here, more than the drugs, I wanna go the timing first. So coronary reperfusion is very important within 90 minutes of medical contact or within 12 hours of symptom onset. So the percutaneous coronary intervention is done within 90 minutes of first medical contact or 12 hours, within 12 hours of symptom onset, within 120 minutes if the facility does not have PCI, percutaneous intervention facility, and we need to transfer them within 120 minutes to a facility which has PCI, which can do the PCI. And now coming to the drugs, nitrates are used with caution because they decrease the BP. And beta blockers, oral cardioselective, we need to give them selective cardioselective beta blockers. Examples are metoprolol, atenolol, and this is contraindicated in heart failure and bradycardia. And antiplatelet therapy, aspirin and P2Y12 receptor blocker, example tricagrel or clopidogrel. And I believe even in part 1 we studied these drugs, but under the topic of drugs commonly used in cardiovascular diseases. And the anticoagulation like unfractioned heparin, enoxaparin, or bivalirudin. Anticoagulants, unfractioned heparin, enoxaparin, or bivalirudin. Statin therapy, hypotension, rosuvastatin, like rosuvastatin and atorvastatin. Coronary reperfusion is done within 90 minutes of first medical contact, within 12 hours of onset of symptoms, and within 120 minutes if the facility does not have a PCI and the patient needs to be transferred to PCI facility. So the next one we are going to study is persistent pulmonary hypertension of the newborn. Why it happens is usually the pulmonary pressure is high in the fetal life to prevent the blood from going to the lungs. And if there is persistent pulmonary hypertension of newborn, the pathogenesis is abnormal persistence of elevated fetal pulmovascular resistance. This causes right to left shunting, In PDA, patent ductus arteriosus, and in patent foramen ovale, we get left to right shunt, but in persistent pulmonary hypertension, we get right to left shunt across ductus arteriosus. Across ductus arteriosus. And this persistent pulmonary hypertension of the newborn is seen in Eisenmenger syndrome, long-standing pulmonary ductus arteriosus. Pulmonary ductal arteriosus should close within minutes, and physiologically, anatomically, it should close within 10 to 15 hours. 10 to 15 hours at birth. Anatomical closure is in 1 to 3 weeks. So functional closure is 10 to 12 hours after birth, and anatomical closure is from 1 to 3 weeks. So the risk factors of persistent pulmonary hypertension is there is a risk of lung hypoplasia, congenital diaphragmatic hernia. So lung hypoplasia, the diaphragm herniate into the lungs and causes lung hypoplasia. Meconium aspiration syndrome, infection, example neonatal pneumonia. Persistent pulmonary hypertension causes is a risk factor for infections. And on examination, what we find is postductal O2 is decreased relative to preductal O2 because the shunting happens after the duct. So the shunting happens after the duct. So if the O2 saturation will be low, and if it is preductal, the O2 saturation will not be as low as this postductal thing. And we see respiratory distress and cyanosis. In this part 2, we are also going to see another condition where we see cyanosis, respiratory distress with cyanosis, and there will be a prominent S2. The S2 will be more prominent in persistent pulmonary hypertension. And the treatment is oxygenation and ventilation, inhaled nitric oxide. Nitric oxide is a pulmonary vasodilator. So oxygenation, ventilation, and inhaled nitric oxide. And I also did a little recap of ductus arteriosus, ductus venosus, and pulmonary patent ductus arteriosus. So as I told earlier, what does the ductus arteriosus do? It connects the pulmonary artery to aorta, bypassing the lungs. It connects the pulmonary artery to aorta, bypassing the lungs. The functional closure is within 10 to 15 hours. Anatomical closure is within 1 to 3 hours. So how does the functional closure happens is there is increased O2. So the prostaglandins lowers, and this causes smooth muscle constriction. The decreased O2, decreased prostaglandins, this causes smooth muscle constriction. And also use this prostaglandins in coarctation of aorta, that will help vasodilation. And ductus venosus, it connects umbilical vein to inferior vena cava, bypassing liver in fetus. The functional closure is within minutes to few hours after birth. The blood flow stops when the umbilical cord is clasped. Anatomical closure is 1 to 2 weeks sometimes. And as I told earlier, in PDA we see left to right shunt, also in patent foramen ovale. Why left to right shunt? The high aortic pressure goes to pulmonary artery. This causes pulmonary overcirculation and then tachypnea. Patent foramen ovale, it's not very common, and the patients are usually asymptomatic. And not patent foramen ovale. Patent ductus venosus is less common. If it is present, it is the features are hyperammonemia and encephalopathy. But patent foramen ovale also causes left to right shunt, but the patients are usually asymptomatic. I think I'll conclude this video part 2.1 with two small topics: how obstructive sleep apnea causes secondary hypertension. So people with obstructive sleep apnea has nighttime apneic episodes. This increases the catecholamine response. This triggers the strong catecholamine response, and this causes secondary hypertension. And if we see hypertension with hyperkalemia, it is maybe due to primary hyperaldosteronism. This is one thing I studied in the other options of the question. So hypertension associated with hyperkalemia is seen in hyperaldosteronism. Then we are gonna see renovascular hypertension. Renovascular hypertension is suspected in patients with widespread atherosclerosis, abdominal bruits, new onset hypertension at advanced age, acute kidney injury after starting ACE inhibitors. Acute kidney injury after starting ACE inhibitors can lead to renovascular hypertension. Recurrent flash pulmonary edema. Recurrent pulmonary flash edema, that is infection like sudden onset pneumonia like features, but it is due to the fluids in the lungs. And resistant heart failure. If there is a resistant heart failure, then we suspect renovascular hypertension. So with this, I'll conclude the video. And another interesting factor I noticed, that if I write anything in blue, my mind thinks of it as an appendage, not so important. I don't have to remember it. So like, for example, this renovascular hypertension thing, I have written everything in blue color. So it's like my mind thinks I don't have to remember them, I don't have to study them. So later in the notes, I have switched to writing wherever I want to use blue, I am using purple. Let's see how my mind reacts and not think of it as something not important and I don't have to study it at all. Because I'm worried now, I'm not gonna remember this renovascular hypertension thing because I have written it in blue. So I'll go over it one more time. Renovascular hypertension is suspected in patients with widespread atherosclerosis, abdominal bruit, new onset hypertension at advanced age, acute kidney injury after starting ACE inhibitors, recurrent flash pulmonary edema, resistant heart failure. Why resistant heart failure is that the renovascular hypertension causes, why resistant heart failure in renovascular hypertension is because the renal ischemia due to the heart failure makes the kidney think there is low BP, and it starts RAA system, and it stuck in a loop of RAA system, and causing vasoconstriction, high blood pressure, high afterload, and refractory volume overload that do not respond to HF therapy because the kidney keeps thinking there is low BP. So the RAA system producing severe vasoconstriction, high afterload, and refractory volume. Just give me a moment, I want to think about a high afterload. The heart is already failed, but it tries to give more load, high afterload, and refractive volume overload that do not respond to heart failure. So the resistant heart failure, this is why we have resistant heart failure in renovascular edema. With this, I'll conclude this part of cardiology part 2, which I'm gonna name as part 2.1. And as always, I hope we pass the exam. Thank you. Peace.